Hello everyone, I'm Preeti. I'm starting a new YouTube channel called Dialogue with Doctors to disseminate information on health issues. Friends, when we fall sick, our suffering is aggravated by our ignorance. So I want to provide authentic and reliable information about health issues in an accessible manner without using any kind of jargon. In each episode, I'll be inviting two medical doctors and engage in an extended dialogue with them to cover threadbare all the aspects of a major disease or disorder. For the inaugural episode of my channel, I have decided to focus on coronary artery disease. Friends, we are living through an epidemic. No, I don't mean the COVID-19 epidemic. I'm talking about the epidemic of cardiovascular diseases. That is, diseases of the heart and vessels. Among cardiovascular diseases, coronary artery disease occupies a very significant place as it affects millions of people all around the world annually. What exactly is coronary artery disease? Coronary arteries are blood vessels which supply oxygenated blood and nutrients to the heart, which in turn supplies this oxygenated blood to the rest of the body. As a result of the disease process, the coronary arteries become damaged. There is a buildup of plaque in them and they become narrow, thus restricting the supply of blood to the heart. The reduced flow of blood to the heart results in a variety of symptoms, such as shortness of breath, pain in the chest, pain in the shoulder and arms. When one or more of these arteries gets completely blocked, it can lead to a heart attack or even heart failure. How is coronary artery diagnosed? What are the signs and symptoms to watch out for? What are the treatment options? What is the recovery process like? And above all, what can we do to prevent the disease? In order to answer all these questions, I have with me two distinguished doctors for a panel discussion today. The first doctor is Dr. Vinod Sharma. Dr. Sharma is an interventional cardiologist and head of the Department of Cardiology Services at National Heart Institute, New Delhi. Dr. Sharma has given a new lease of life to thousands of patients of CAD. The second doctor on the panel today is Professor Abid Geelani. Professor Geelani is a cardiothoracic surgeon and head of the Department of Cardio-thoracic Surgery at B Pant Hospital, New Delhi. Professor Geelani too has treated countless patients of coronary artery disease by performing bypass surgery on them. Both of these doctors are leading lights in the field of coronary artery disease. I welcome you both, sir. Now, without further ado, let us plunge into the discussion on coronary artery disease, which I will refer to as CAD. Let me pick their brains and let's get to know more about CAD. Please stay tuned till the end of the episode to know all about CAD. Dr. Sharma, yes. In our day-to-day life, we hear dreaded words like angina and heart attack used almost on a daily basis. But we don't really know the difference between these words. What exactly do you mean by angina and heart attack? Yeah. Can you please explain?
Yeah. Preeti, as you said in your introductory remark, that coronary arteries are the tubes which supplies oxygenated blood to the heart muscle. And when this artery gets narrowed, then they produce a variety of symptoms. So a kind of chest discomfort which this narrowing produces, in technical term, that is called as angina. Now, the word heart attack is a layman term. As you mentioned that these arteries can get narrowed either gradually, and therefore they give a gradual symptom. What we call as a stable angina, when patient walks or does some activity, then he gets some discomfort. That discomfort is angina. But sometimes these arteries get suddenly blocked with the clot. And when there is a sudden cessation of blood supply to the heart muscle, so area of heart muscle get damaged. That is what is actually heart attack. or in technical term that is called as acute myocardial infarction. So angina is a word used to describe that symptom, and heart attack is a damage to the heart muscle due to sudden instantaneous occlusion of the arteries of the heart.
So if I understand it correctly, sir, can a patient have angina for several years without having a heart attack?
Yes, let's see the natural history of coronary artery disease. Coronary artery starts narrowing, say like at some point of time, and as the artery gets narrowed, the supply becomes less, especially on activity. So a person may initially remain asymptomatic, no symptom. As the narrowing increases, then he starts getting symptom on exertion, a particular level of exertion, a particular threshold of exertion that gives him symptom. That is called as a stable angina. And then these patients, some of these stable angina patients over a period of time, as their narrowing increases or there is a superadded spasm over the artery or clot formation over artery, they start getting pain at rest, discomfort at rest. Then this stable angina turns into unstable angina. And some of these so-called unstable angina may have sudden occlusion of an artery and would lead to the heart attack. So this is a four different phases on the natural cycle of a atherosclerotic narrowing of coronary artery. Okay. Phase 1, when they are asymptomatic. Phase 2, when there is a gradual narrowing, but narrowing is not critical, they get angina or discomfort at certain exertion, then they start getting discomfort at rest, and then one of them may develop sudden instantaneous occlusion and heart attack.
Dr. Geelani, can you please explain how does coronary artery disease develop? As I've understood from Dr. Sharma's explanation, the disease seems to develop over several years. It's not like an acute incident. It's like a process which spans over several years. Is that so, sir?
Yes, it is as Dr. Vinod Sharma has said, that it is a gradual progression of diseases, and the blockage usually occur over a period of decades. But there are some patients where the narrowing is, suppose, for example, if the narrowing is only 25%, 20%, then the patient will not have any problem. He will lead a normal life. He will be able to do some exertion work also. But suddenly, if this 25% becomes 100%, then he will develop the heart attack, what you call, it is in a late man terms, it is called MI, myocardial infarction, short form of the myocardial infarction. They will say that the patient has developed MI. So that MI, so it is a gradual process, but it is not rule for everyone. But in some patients, it can develop very suddenly. And these are those patients who will have the sudden death. You may have heard this, that he was very young and no problem with him, and he was going to gym. He was doing cycling for 8 to 9 kilometers every day. In spite of that, he suddenly one day he had the chest pain and he collapsed and he is no more. So this is they are the people who had developed sudden blockage of the coronary artery disease. And so it is usually a gradual process, but it is not rule. In some patients it can develop suddenly, and if it develops suddenly, then the nature does not get the time to provide the alternative way of alternative supply to the heart. So when the nature is not able to do, because nature will also need some time to develop, because the nature is always protective. Nature will try to protect you so that the ill effects are very less. But since the blockage is occurring suddenly, the nature has not developed the remedial measures, and the patient will have the severe problem. As far as the you wanted to know whether what is the reason why, what is this atherosclerosis means? Atherosclerosis means the blood is there which is going through the arteries. Blood is carrying some form of cholesterol also. they are having the cholesterol, they have got the triglyceride and the other various forms of the fat and the lipids. These lipids, if there are sometimes there is some accumulation of the fat on the wall of the arteries, whether it is a coronary artery or it is some other artery of the blood of the body. So when there is this aggregation or the accumulation of the fat, and this will call as atherosclerosis, because over a period of time this will gradually progress. This deposit, which was earlier, it is usually soft, it will become hardening, it will start hardening, and after over a period of decades it can be even become calcified. Means calcification will also get deposited, calcium will also get deposited over this. So these are the soft plate, initial plate, which are soft. They are dangerous. Once they become fibrous or once they become calcified, they are less dangerous. They will not develop anything suddenly. It is the soft plaque which are notorious. They are usually, suppose they are 10% blockage is causing, and suddenly it will become 100%. So these are the soft plaque which are notorious to go into the sudden transformation into 100%. Otherwise, the fibrous or the calcified plaques are not so dangerous for the sudden death. Other thing is, one is this fat. So that we can know whether the patient is having the cholesterol in his body, that we can test it from the blood test, whether the patient is having some derangement in the level of the blood, which is abnormally high, or in few cases, it is not always the fat which is responsible. In few patients, it is soft. There may be the soft clot. Blood clots can form into any of the chamber of the heart, mainly the left side, what is called the left atrial appendage. There, the blood clot can form, and from there, if this clot goes, and unfortunately, if it goes to the heart vessels, they can also suddenly block the coronary artery. So these are the two main reasons of developing the coronary artery disease. Other than the congenital, there are few people who are congenitally prone for this coronary artery disease also. One is the genetic that we will discuss afterwards, but other is the anatomical variation in this, because they will find in some patients that the coronary arteries are taking abnormal route. Instead of the normal route, they are taking abnormal route, and through that abnormal routes, they can become the narrow, then it can become normal, it can become, so when the heart contracts, it becomes narrowed. When the heart relaxes, it becomes normal. So that is the dynamic narrowing of the coronary artery disease, which we called in a medical term as a myocardial bridge. So that is also one of the type of the coronary artery disease which is there. And so these are the basically three types which we say. But the most common, if you say the coronary artery disease, it means it is the atherosclerosis.
Thank you, sir. If I understand, the disease seems to be so insidious. It seems to be kind of creeping upon us without our knowing. Our arteries seem to be getting blocked and getting narrower by the day, and plaque buildup, as you described it, and this process of the buildup of plaque, which restricts the supply of blood to the heart. Now I'll turn to Dr. Sharma. Sir, what are some of the risk factors for developing CAD?
Yes.
Could you outline these risk factors for us?
As Professor Geelani said, that the key pathology feature of the coronary artery disease is that atherosclerosis, the deposition of cholesterol plaque inside the coronary artery, and on the top of this plaque, blood clot forms and occludes the coronary artery, and that is what gives rise to this problem of acute or chronic coronary artery disease symptom. Now, there are risk factors. They are truly not the cause. They are just the risk factor. So we have two sets of risk factors. One group of risk factors are unmodifiable. We cannot modify by any intervention. They are like age. As person ages, chances of coronary artery disease or atherosclerotic disease increases. Male sex, comparing in the population, males have more propensity to develop coronary artery disease. Female have that immunity, protective immunity from the estrogen. So till they reach menopause, they are relatively immune to coronary artery disease. But once they reach menopause, thereafter, their propensity to develop coronary artery disease becomes nearly same as male. So another is a male sex. And third is a family history. If there is a strong family history, especially the father develops coronary artery disease below the age of 50 and mother develops below the age of 55, then chances that children have coronary artery disease is more. So these are the three non-modifiable risk factors, which we cannot modify. We cannot modify the age, we cannot modify the sex, we cannot modify our genes. But there are set of modifiable risk factors. Commonest in the population is the diabetes, overweight, that is obesity, smoking, high blood pressure, physical inactivity, the dietary pattern, diet rich in saturated fat. So these are the modifiable risk factors. We can control diabetes, we can control hypertension, we can control our weight, we can engage in physical activity. So we can stop smoking. So these are the risk factors which we can control. So that's how these are the modifiable risk factors. So if we see in totality, in majority of the population have risk factors, those who develop coronary artery disease. But something around 28 to 30% of people, you do not find any of the risk factors. Still they get coronary artery disease. So to summarize this risk factor thing, these modifiable and non-modifiable risk factors are there. But not that everybody who has this risk factor would develop coronary artery disease. Majority may develop. Similarly, those who do not have any of the risk factors, not necessarily they are immune to coronary artery disease, they can also develop. Okay. So we have to identify risk factor and accordingly intervene.
If I understand correctly, sir, as you made a distinction between risk factors of two types, right? Age, sex, and our genetic makeup. Those are the factors which are beyond our control. We can't change them. And the second set of risk factors, which pertains to our behavior, our lifestyle, those are things which are to a large extent within our control. Our eating habits, our lifestyle, do we smoke tobacco, even diabetes to a certain extent, I suppose. From this, I would like to ask you, sir, Dr. Sharma, would you describe that among the second set of risk factors, would you say that the patient who is more likely to develop coronary artery disease, should he or she suffer from a certain combination of these risk factors? Or are you prone to developing the disease, even if you are just a smoker, you're not a diabetic, you're not a hypertensive, you have an active lifestyle, but you are just a smoker. So does that put you at an equal risk of developing the disease, or is it a certain combination of these factors?
See, anybody can have any of the risk factors, any of the modifiable risk factor can develop coronary artery disease. If someone is only diabetic, he or she can develop. If someone is only smoker, he or she can develop. But when there is a combination of risk factors, if someone is diabetic, hypertensive, overweight, and also a smoker, his chances of developing coronary artery disease become very high.
Right.
And especially when we talk about some of this modifiable risk factor, their effect when they are together in a person, their effects are not additive, it is multiplicative.
Okay.
So when we talk about if we see in the population, what are among these risk factors, which are the commonest one? So if we see the commonest one are diabetes. In population, almost that 23 to 25% population is diabetic, and equal number of people are so-called in pre-diabetic stage. So diabetes is one of the major risk factors. Majority of these diabetics are either hypertensive and also obese.
Right.
Similarly, the smoking or tobacco consumption in any form, not necessarily smoking only, even chewable tobacco. So tobacco consumption in various form is quite common, especially the young population who may not be diabetic, but they are mostly obese and they are a smoker.
Right.
The middle-aged and elderly population, they are diabetic, they are chewing tobacco or smoking, and also the obese. Similarly, the majority of this diabetic are hypertensive also. So
Right.
most of the time there is a combination of risk factors.
Right.
So even the one risk factor in isolation can produce coronary artery disease, but when the risk factors are together, their effect get pronounced.
Right. If I understand correctly, sir, combination of risk factors, more than one risk factor, as you said, is not additive, but it's multiplicative.
Yes.
So the probability of the patient who has several risk factors, who could be a smoker, who could be a diabetic, could be a hypertensive, could be obese, and could be leading a very unhealthy and sedentary lifestyle. So such a person would be at a much, much higher risk
Much
of
higher.
developing the
Yes.
disease. Is
Yes.
that so? Right.
Yes.
Okay. Dr. Geelani, I'll turn to you now. Sir, as you said in the last answer, that you had said that our genetic makeup, right, the genes that we inherit from our family, that also contributes to developing CAD. So if as Dr. Sharma also said, if our family members, if our father or one of our parents had suffered from coronary artery disease before the age of 50, we are then at a higher risk, sir, of developing the disease. So
Yes.
our bad genes are equally to blame, I suppose, then.
Yes, the genetic makeup of any individual, what has been inherited from his parents, they play very important role.
Right.
And these patients are at a higher risk, especially if there is a combination of the other risk, and these risks can not be modified. This genetic, you cannot do anything for this. It is not modifiable. So that's why it is very imperative in these people that they should take lots of care if they are having some other risk factor. And one important thing is that these are the people who will present very young, because we are seeing now the very young people coming with a coronary artery disease.
Yes.
Earlier it was said that only the elderly people or more than 40, 50, they are coming. But now what we are seeing that the younger people are coming. The youngest person I have operated for the atherosclerosis is hardly 21 years old. 21 years old person developing a atheromatous coronary artery disease, not any other cause. It is not congenital or it is. So these are the patients who are having the genetic predisposition. They usually present early than the normal atherosclerotic lesions. And the person has to be very careful, those who are having the familial history of the
Right.
coronary artery disease.
Right. So this is very important for our viewers to be watchful about, that if one of your parents has already suffered from coronary artery disease, then all the more reason for that person to be careful about the modifiable factors that are within his or her control. Dr. Sharma, many times we hear about a person who has suffered a heart attack, but who had no previous history of medical illness. He seemed to be leading an absolutely healthy life. And then all of a sudden, he suffered from a heart attack. So how can such a situation develop?
It can happen, and we come across this scene very often. As Professor Geelani said in how the atherosclerosis form. See, this cholesterol plaque start developing in the lumen of the artery gradually. Initially, this plaque are soft. They are just rich in cholesterol. Over a period of time, there is a so-called fibrosis and calcification takes place, and this plaque becomes stable. But many of this so-called soft plaque, suddenly they may rupture and clot may form over it, and person may develop heart attack. So a person who was till yesterday said to be medically fit, no medical illness, can have such situation where already he was forming a cholesterol plaque, soft plaque, which ruptured. Now, we have come across a couple of cases like people who are going to gym,
right,
and while doing strenuous exercise, they developed chest pain, and when they came, they had a heart attack. Now, what we found, basically, he had a atherosclerotic disease, and which during exercise, when the shear stress in the circulation increased, that caused rupture of the plaque and clot form over that segment, and person developed heart attack. So number one, anybody who is looking healthy and is healthy can have this problem, because we do not know inside artery that atherosclerotic plaque is developing.
Right.
And for the plaque to give heart attack, not necessarily it has to be critically narrowed. Rather, literature-wise and experience-wise, I'm sure Professor Geelani would agree with my view that most of the heart attack occurs in the so-called insignificant lesion in the coronary artery, which are otherwise insignificant, 40-50%, 40% disease there. So any healthy person can have this problem if there is an undiagnosed underlying atherosclerotic coronary artery disease.
Right. So, sir, even if I understand correctly, even if one is asymptomatic and seems to be fit and fine, the process of atherosclerosis, as you describe it, could be going on in our arteries, narrowing them, and the plaque buildup could be taking place.
Yes.
And we may be totally unaware of it because we have no symptoms.
Yes.
Okay. Sir, what is the diameter of the coronary arteries? How wide are they?
See, these are the
Just
coronary
understand.
artery has a main trunk and they branch gradually.
Right.
So average diameter, because Professor Geelani, being a cardiac surgeon, is every day opening and seeing, but we are seeing these arteries in the screen. So
Right.
average Indian diameter varies from 2.5 millimeter to 3.5 millimeter. The left main artery, which is right in the beginning, that is about 6.5 millimeter. But most of the major coronary arteries are somewhere between 2.5 to 3.5 millimeter in diameter.
Right, right. Okay, so, sir, as you made a distinction between angina and a heart attack, that, one is you can have a stable angina, and then you can have an unstable angina, and then you can have an acute incident like a heart attack. What are exactly the kind of classic signs and symptoms of the dreaded heart attack?
Yes. Again, when we talk about the symptoms of the heart attack, there are two sets, typical symptom and atypical symptom.
Right.
Typical symptom is those chest discomfort,
right,
or heaviness or squeezing sensation.
Okay.
People describe it as कि सीने में कुछ भारी सा रख दिया गया और खींच रहा है, जकड़ रहा है. So that squeezing sensation that is there, mostly it is in the central chest, right side of the chest. It goes to the arm, mostly the left arm, but it can go to either arm. It can spread to the neck, jaw. Sometimes people present with jaw pain only. Sometimes the anatomical distribution of coronary artery, especially one of the artery, left circumflex artery occlusion, is notorious for giving discomfort or pain only in the back, in the interscapular region. People feel pain either at rest or on activity only on the back.
Okay.
So these are the classical symptoms of discomfort. Along with that, there may be sweating, there may be palpitation, or people describe it as ghabrahat. There may be sinking sensation. So these are the classical symptoms, typical symptoms. But there are atypical symptoms also.
Could you describe those also for us?
Atypical symptoms are, say, like somebody starts having discomfort in upper part of abdomen, just below the chest.
Right.
Some abdominal fullness, belching, they describe it as a gas.
Right.
Sometimes nausea, vomiting. Sometimes they have just, a person has exhaustion, unexplained exhaustion, tiredness, or shortness of breath. So these are the atypical symptoms. So many a time, all these atypical symptoms, especially this gas type of symptom,
right,
belching or kind of fullness or flatulence, they described it, they dismiss it thinking it is a gas, which it may not be.
Right.
These are the atypical symptoms.
So, sir, you seem to have anticipated my next question, which was about how, like, for instance, chest pain or pain in the stomach can be because of heart attack, but it can occur in other medical conditions also. It can occur when there is indigestion Or so how is a lay person to distinguish whether this is a heart attack or whether this is an innocuous condition for which he or she can take Digene or some kind of a, medicine to relieve gas or indigestion?
See, both the physician and the patient themselves have to dissect this symptom. Dissect in the sense, suppose there is a symptom of gas, flatulence, which is coming suddenly, which a person has never experienced. Most of the people who have so-called gastritis, they keep feeling this symptom off and on. Anything which is a new onset, unusual.
Okay.
Nothing to relate to the food or type of food. If someone had a spicy food from outside and developed such burning sensation or flatulence, it can be probably gas. But as a routine, if someone has developed a new gas type of symptom, then it should warrant the further investigation. Similarly, the chest pain. Chest pain can be there due to heart disease. Chest pain can be there due to multiple other reasons. Because in the chest, there is a skin, there is a bone, there is a lung, there is a pleura, all can give rise to pain. But there is heart also. So discomfort of cardiac origin, mostly, of course, it is a sudden in onset, but it has a very peculiar discomfort.
Okay.
Unlike the pain of, say, like costochondritis, that inflammation of the bone of the chest, the bone ribs, which is joining the central bone sternum, it produces a localized pain. It is not diffuse. It doesn't radiate.
Okay.
And the pain is constant. Discomfort of the coronary artery disease, it would come, it will either build up or after some time it will disappear. But this, suppose we are talking about, say, like pain of costochondritis, pain will be there all the time. Similarly, pain due to pleuritis, it would aggravate with the breathing. There would be accompanying fever or other symptom. So we have to correlate with other symptom also.
Okay.
But as far as this gas symptom is concerned, yes, it is most innocuous, because half of the heart attack patient, they miss the timeline because they keep thinking that this is a gas. Not only the patient, even physician make mistake. This is just a gas. So any symptom which is very unusual coming first time, especially in the people who are a risk model, having a multiple dose risk factor. Because same thing happening in a thin person who is non-smoker, non-diabetic can still be gas. But a diabetic patient, a smoker, says suddenly I am developing such symptom, it should be viewed as suspicion.
Right. So if I understand correctly, sir, those who are already who already suffer from a variety of risk factors, which you outlined earlier, they should be alert and vigilant about anything unusual happening, any kind of pain which they are experiencing for the first time, that needs to be investigated and maybe calls for a visit to the doctor, I suppose. Sir, also, sometimes we hear doctors using words like a silent heart attack. What exactly, what do they mean by that?
Silent heart attack is a terminology when we use that we found the evidence of heart attack in, say, like ECG or echocardiogram or a incidental blood test, cardiac enzyme done. But person says, I never had any symptom. This is a so-called silent heart attack. Now, diabetic patients are particularly prone for it, because diabetes, in the process of its progression, it damages the nerves which carries the pain sensation from the chest and heart area. So these are the people, diabetic people, they may have heart attack without any symptom. But heart attack is evident in ECG or an echocardiogram or in the incidental blood test.
Okay. So such people may not have suffered any kind of symptoms while they had the heart attack, or they would not have the sensation, probably because they are suffering from diabetes and they have neuropathy, I suppose. Is that why?
This mostly in diabetic, this absence of pain is due to neuropathy.
Okay.
Now they suffered heart attack, but without having any symptom.
Okay.
It happens especially if the area involved in the heart muscle is relatively small. If it is a larger heart attack, it will bring some symptom or in other thing like hemodynamic disturbance. That means sudden variation in pulse rate or blood pressure. So if it is a small or moderate size heart attack, it may go unnoticed. And that is silent heart attack.
Okay. Dr. Geelani, I'll address my next question to you. Who are the people who are more likely to develop coronary artery disease? Both of you have already spelled out the risk factors. Those with these risk factors are more predisposed to developing the disease. My question pertains to people who lead stressful lives, who are very competitive, who are very ambitious. In short, people with A-type personality. Such people, are they more predisposed to developing coronary artery disease?
Yes, the risk factor we have already mentioned earlier. And so they stand here also, but what you said, ki type A personality.
Yes.
I would be very specific in that, ki those who are ambitious, I would not include that in that. Okay. Those who are they want good early money, huge money, all these things, that will be there in each and every one. So I won't take it. What I find in my practice, and what I found that this is the stress is the thing which plays. Okay, how much stressful is your life, whether at home and at your workplace? You have to see that, and there's nothing wrong in being the ambitious, but you have to find that the environment where you're working should be less stressful. And when you go into more what type of stress, work stress, then the stress at home, the children and wife, all the stress will be there. You cannot change it. But what is sudden surprise? This stress, which is because of the unexpected reason, that is more dangerous than this workplace and other things. So we should try to be very happy, and this is the part. This we can if we include the yoga and other things, yoga, meditation, other things, we can take care of this part of the risk, which is there in each and everywhere. We cannot modify much.
So, sir, what you mean to say is that stress is an unavoidable part of our life. We can't weed it out, but we should learn to manage it and reduce it as much as we can by resorting to therapies like yoga, meditation, and various other calming techniques. Dr. Sharma, my next question I will address to you. There's a lot of talk about undergoing annual health checkups, right? There are hospitals also which advertise various kinds of packages for annual health checkups, and they are also targeted towards a particular kind of constituency or audience. Which kind of tests would you recommend for people to undergo annually? Would you say that people who are more at risk, people who already suffer from these risk factors, who are diabetic and who are those the kind of people who should undergo these tests annually, right? And which kind of test would you recommend for such group of people to undergo?
See, the concept and design of health check came with the idea to keep their employees healthy,
right,
and gainfully employed by the different corporate body. But that subsequently translated into the general population. Right. So health check today, it has both scientific reason also and commercial reason also. So if we go more by a scientific dictate, yes, people who are at certain age and especially with the risk factor, then routine health check should be done. Right. Now, when the person reaches a particular age, say like beyond the age of 40, then the chances of developing many of these lifestyle diseases become more, because many of the people are diabetic, they don't know they are diabetic. Many of the people have high cholesterol level, they don't know they have high cholesterol. So to pick up this pathological process early in the disease and intervene so that this disease can be modified and the heart disease can be prevented. So that is the idea behind the health check. So my take on is that yes, all the people who are at a particular age, say like 40 and beyond, and especially if they have family history or they themselves are diabetic or high blood pressure, or they are engaging in a unhealthy lifestyle, that they are overweight, they don't exercise, they are a smoker, then altogether there is necessity of doing health check. Coming to these are the advantage, no doubt. We pick up the disease or biochemical abnormalities in our system early in the process so that we can intervene. But there are downside of health check also. People are absolutely healthy. Sometimes when they go health checkup and they find some of the abnormalities and they end up in a vicious cycle. Especially it comes to the heart disease, then this problem is more. Like in health, most of the health check package has a non-invasive testing like treadmill test.
Right.
Person undergoes treadmill test, he is absolutely fit, asymptomatic, and treadmill test come positive.
Right.
Then he has to undergo the next test.
Right.
Next to next. So like that, he is declared he has a blocked artery. Right. Now the question at that point of time, question comes, should we do intervention or we manage medically? So they end up in a vicious cycle. So right. Selection of the person for a health check should be based on his risk factor profile, especially age and other accompanying risk factors. As far as the type of test pertaining to the picking of heart disease is concerned, other than basic clinical examination, we just need basic biochemical profile in terms of picking up diabetes. So blood sugar, fasting postprandial blood sugar, a marker of glucose control is a HbA1c, lipid profile, basic liver and kidney function test, and basic non-invasive tests like ECG and stress test and echocardiography. That is good enough to declare a person whether he has any underlying disease or any underlying biochemical abnormality, or sometimes, we pick up person already has silent heart attack and there is a evidence in the echocardiogram, or we pick up some other undiagnosed disease. Many of the congenital heart diseases are undiagnosed. Sometimes a large heart is undiagnosed. So those things can be picked up. So there is a role of health check, but it should be directed towards the people who are at risk.
Right.
Not for a 25, 30-year healthy young person to have a health check.
Right. Sir, you've explained very well the fact that not everybody needs to indiscriminately go for these annual checkups. Only those who are more predisposed and more vulnerable to developing the disease, who have a certain kind of risk profile, they are the ones who should go for these tests. And even these tests are a certain kind of tests, as you said, diabetes, hypertension, lipid profile, rather than going in for a battery of tests which are not really needed. Okay. So my next question is to Dr. Geelani, sir. Dr. Geelani, it is, as you said earlier also, the disease comes with the passage of time. It's an insidious process spanning over decades and years, right? And you said that young people are also vulnerable. So is the progression of the disease, the trajectory of disease progression, is it the same in older people or is it different in younger people? How does the disease develop and what kind of course does it take in older and younger people?
Yes, it is a very important question. And it is said about the coronary artery disease or in fact you can say about any other arteries also, because there are many arteries of the body, and when this body, like the arteries which are supplying to the heart, what we are talking about today, there are other arteries which are supplying to the other vital organs. So like to the brain, if they can also develop blockage, they can also have the brain stroke. These vessels are also, the kidneys are also vital organ. If they are also supplied by the blood, and if their supply is also blocked, they will also have. So this progression of the disease is not only for the heart, it is for the whole body, even into the leg also. The leg arteries are also involved. You may find that the person is having leg pains without any reason, and he is not able to walk. If he walks, he develops pain, and then after the leg pain, there may be some blackish discoloration. So what I mean to say, because this vessels, it can involve the other organs also. It is not all alone only for the heart. So the person has to be very careful. If they are having the other symptoms to the other part, that will also give a clue. Yes, this patient is having some coronary artery disease, and his coronary artery disease may also be developing.
Right.
So that
This
is
is
one
a-
important thing. And
Yeah.
like after 60 years,
Yeah.
well, if you do the angiogram after 60 years, you will find invariably almost more than 50% people will have some of the blockage. May not be significant enough, but they will be having some blockage. So it is said that if it is above 60, it is not the fault of the person. If the coronary artery disease is occurring below 60 years, yes, it is because of the fault of the person or the fault of his ancestors.
Right.
So this we have to see.
Right.
We should know.
Right.
As I have already mentioned that the course in these two subgroup, younger group and the older group, are entirely different.
Right.
It is very slow and insidious. Like if the 60%, if the person is more than 60% and he develops blockage of around 60 to 70%, it is very harmless. It will take another 10 to 20 years to develop it into 100%. If he is taking medicine and other precautions. But the same disease, if it occurs in a younger, like 30 years, 35 years, this disease will progress very fast.
Right.
And this person will land up in having 100% blockage from 60% or 50%. It will land up into 100% within a period of 5 to 10 years itself. In spite of taking medicine, in spite of taking precaution. So one has to be very careful in this because the course is very aggressive and it is very, we can call it a malignant course. It is not only aggressive, it is a very malignant course. So this patient, the younger the person, they should be, the disease is very dangerous in them, like in the elderly person.
So, sir, you've signposted two very important points for us. One, that the progression of disease in younger people who have suffered from CAD, it's very dangerous, it's very fast, it's very aggressive, and they need to be more watchful because the blockage of arteries is going to not take that many years, as opposed to older people who develop CAD. The course of the blockage and narrowing of arteries may take several decades for them. Right. The second thing, sir, which you said, which I want to highlight for my viewers, is that the process of the blocking and narrowing of arteries pertains not just to coronary arteries. You said that even the other arteries which supply blood to the brain or to other vital organs of the human body, they also suffer from the same process. So one has to be watchful not only about coronary arteries, but the process of atherosclerosis affects arteries supplying blood to the other organs of the body also. It's an extremely important point for our viewers to pay attention to. Dr. Sharma, my next question, which you had referred to earlier also, about women having a lower incidence of developing coronary artery disease. That is it true that fewer women have heart attacks in comparison to men? And is it true that women are less vulnerable to develop the disease than men because of their hormonal makeup? What is it which gives them that protection till menopause?
Biologically, women chances of developing coronary artery disease in women is less till their menopausal age.
Okay.
But there are several negative modifiers which have come up.
Okay.
Many women are turning a smoker.
Right.
Many younger women are obese.
Right.
Many women have turned diabetic early age, and many are using oral contraceptive pills.
Okay.
So these negative modifiers have changed the kind of a natural cycle.
Okay.
Otherwise, if we see in a woman who is reasonably active, average built, till her menopause, her chances of getting heart disease is less. Beyond the menopause, her chances of getting heart disease become same as male counterpart.
Okay.
That protective immunity offered by estrogen goes over.
Okay.
But as we see with the changing lifestyle, urbanization, the more and more women are falling into one of those four categories. Either they are turning grossly overweight or diabetic, or their food habit is such, they are smoking, or many are using, working women using oral contraceptive pills.
Right.
So that is making them more vulnerable. As far as their so-called, when the women and heart disease, it is not that in women it is mild. They are equally affected.
Okay.
Rather, they are the one who present late, because most of the time the symptoms are dismissed as a casual symptom.
Right.
So that many a time the diagnosis is late in the women. And if we see the prognosis wise, men versus women, women with coronary artery disease, her prognosis is a bit unfavorable compared to men.
Okay.
So what risk factor identification and control which is applicable to men, it should be applied equally to the women also.
Right.
Because other than forget about the natural immunity, but those negative modifiers are, their numbers are increasing.
Right.
So they have to be viewed same as a male counterpart. No doubt they have certain degree of immunity.
Right. So as Dr. Sharma has explained, the natural immunity that women enjoy because of their hormonal makeup is compromised by the risk factors like diabetes or hypertension or a sedentary lifestyle. So I'd like to tell my women viewers that let's not be complacent. Let's lead an active and healthy lifestyle, and let's be watchful and vigilant. Let's not think that we are not prone to coronary artery disease. So Dr. Geelani, my next question is to you. When somebody suffers from chest pain, somebody has an attack of chest pain at home, what should the family members do in such a situation? It's difficult for lay people to distinguish between an innocuous chest pain or chest pain, which is actually angina. So what should they do? What kind of measures can they take in such a situation?
The first thing, the relatives and the patient, I would suggest to the patient and relative both, they should not panic.
Right.
Because this is not a disease which is not treatable, which cannot be cured. So one, they should not panic. That is one. Second thing, they have to identify whether they are really having the heart problem or it is some other thing. So they should know the typical presentation, like the chest pain on the left side. If it is, the pain is radiating, it is coming to the arm, it is going to the neck. And if, but even they are having palpitation or they are having perspiration. So
Right.
they should think, yes, they may have the heart attack, and they have to treat in that, they should be treated in that direction.
Right.
Like the gas problem, what if, like Dr. Vinod has already mentioned that the people who say it is a gas problem, but we have to identify if the person has not has not gone for dinner somewhere, he has not taken spicy food on that day, or this gas problem was not earlier there but has happened first time, then they should think it is not most likely because of the gas problem and other gastric reason. And this pain, we have to rule out whether the patient is having the cardiac problem or not.
Right.
So in that situation, what is suggested, that the patient should go and get the ECG done, because it may be available in the nearby places.
Right.
And the person should know whether the pain is persisting or not. If the pain is persisting beyond 1 hour, they should not wait at home. They should go and get the ECG done. If the ECG shows some changes, then obviously they have to go. If the ECG is not showing any changes, then they have to be a bit relieved that most probably they are not having the cardiac problem. But still there is chances, a small percentage of the people may have the non-ST changes. Means the ECG will not show any change, but the patient may be having the heart attack. So that in that situation, if the pain persists beyond 2 hours, ECG is normal, then also they should go and they should get their blood, like enzyme tests done, so that will rule out whether the patient is having the cardiac problem or not. The importance of the 1 hour, 2 hour is that we should not waste time. because if the heart attack occurs, the blood supply to the part of the muscle of the heart is not adequate, so the patient will die if it is not treated within 6 hours. So the 6 hours period is there. So 1 or 2 hours you are wasting in the diagnosis. So still you have the 4 hours, you can go to the hospital and get the needful done if it is a heart attack. So this is the importance. And if it is beyond 6 hours, then this damage becomes irreparable. We cannot do anything for with that, and the nature will take care of them. So this 6 hours period is very important. So they should wait for a 1 hour, and certainly not beyond 2 hours if the pain is continuous and it is persisting, or it is, even if it is increasing if it is increasing in severity.
Right.
And this thing was more true about the diabetic patient, because the diabetic patient may not have the mild pain, other they will ignore it. It will not present because most of the silent MIs are usually present in the diabetic patient. So in the diabetes, this is not a very clear, but means it is not a very clear indication if the patient is having a. But if suddenly if there is a chest pain and it is typical type, then they should report to the hospital.
Right. As you said, sir, time is crucial, and people who are more prone to certain risk factors and hence more likely to develop CAD, they should be more watchful, and even symptoms which look innocuous should be investigated, and they can undergo an ECG as well as the blood test that you specified. I'll turn to you, Dr. Sharma, now. How exactly do you diagnose coronary artery disease? What are the diagnostic tools for diagnosing the disease?
See, the basic diagnostic tool starts with a good clinical and risk factor history taking. Most of the time, one can make out with this a particular person, his demographic profile and type of symptom, whether it is a coronary artery disease or not. But yes, we need to have a more objective proof. To have objective proof, basic investigation is electrocardiogram. So basic ECG, sometime first ECG in setting up new onset, sudden onset chest pain, first ECG may not show changes. So one has to repeat after 1 hour, 2 hours. Or the people who are having so-called angina without having heart attack, the ECG may be normal. Okay. So basic tool is one ECG. Second to that is the blood investigation. We can do a point of care test like troponin T or I in setting up acute chest pain, whether this chest pain is of cardiac origin or non-cardiac origin. Okay. Third is a basic, nowadays in major hospital, echocardiography is available. One can immediately see the heart muscle. Right. So whether is there any area of the heart muscle which is weak, which is not contracting, so one can make out. Even sometimes ECG is normal, we can make out an echocardiogram. So when these tests are done, these are the basic non-invasive testing. The people in whom the suspicion is of so-called low or intermediate probability of heart disease, young person coming with atypical symptom, then one can go for a CT angio, CT coronary angiography. CT coronary angiography has a very high negative predictive value. One can rule out coronary artery disease very well. Or CT angiography has added advantage. Some of the other critical illness which can give rise to chest pain can be ruled out. And next to that is, suppose when we are sure that person has a coronary artery disease and these investigation like ECG, echo, there in concordance, there is a suggestion that person has coronary artery disease, then final test is a coronary angiography. Coronary angiography is a gold standard to diagnose obstructive coronary artery disease. It is a very simple test done through the small puncture either through the arm or in the groin, and a fine 2.5 millimeter diameter catheter is inserted under local anesthesia, and we can picturize coronary artery. We can define extent and severity of coronary artery disease very well. So coronary angiography is a gold standard test to diagnose coronary artery disease. Right. Now, CT coronary angiography is there. Yes, it is to be utilized for a screening purpose in the people in whom the probability of coronary artery disease is low or intermediate, or whenever we want to screen a high risk population which is not symptomatic, then one can have a CT coronary angiography. But those people in whom symptoms are very much suggestive, ECG changes are there, it is good to have conventional coronary angiography to define extent and severity of disease and to decide the modality of treatment, whether we leave them on medical treatment or percutaneous intervention or surgical revascularization.
Right. So, sir, you made a distinction between conventional coronary angiography, which is invasive in nature. You described the process, and I suppose it's an absolutely safe procedure in hands of competent doctors like you. And you also talked about the second kind of angiography, which is CT angiography. And you said that the potential patients groups for both kinds of angiographies are different. That people with high risk profile, but people who are asymptomatic, who have no symptoms, they should go for a screening as far as CT angiography.
Yes.
So, sir, would you say that CT angiography gives as accurate a result in revealing CAD as the conventional angiography?
If we compare, if we look the two, CT coronary angiography and coronary angiography, conventional coronary angiography, truly CT angiography is more informative. In angiography, we are injecting the dye in the lumen of the artery. We are seeing just the lumen.
Right.
And we are inferring the narrowing because the lumen is narrowed. We are not seeing the wall of the artery. Atherosclerotic disease is in the wall of the artery, not in the lumen.
Right.
So by that criteria, CT coronary angiography is more informative. It gives idea about the wall. It gives idea about the atherosclerotic deposit, whether it is soft plaque, whether it is hard, whether there is a calcification, how much is the luminal narrowing. So no doubt CT angiography has a bit upper edge as far as the quantum of information which we obtain is concerned. But as on today in a conventional practice, still the coronary angiography, conventional coronary angiography is taken as a gold standard.
Right.
But as I said, it is just a luminogram. We are just seeing the lumen, not the wall. And to treat the atherosclerosis in totality, we need to see both wall and lumen.
Right. Sir, you've explained really well what are the distinctions between the two types of angiographies, what are their potential uses, and what kind of patients should go for either of them. Our viewers, coronary artery disease is a vast topic. All the aspects cannot be covered in one day. So this is the first part of a two-part series on coronary disease. I'd now like to conclude this particular episode by thanking the two doctors who have so kindly and graciously consented to give their time and answer all the questions. I have, viewers, learned a lot about CAD today. I hope you too have. Please give your feedback in the comment section below. Stay tuned for the second part and the second episode on coronary artery disease, where we will be discussing with Dr. Sharma and Dr. Geelani the treatment options, the various treatment options for coronary artery disease, how to manage the disease, how is the disease going to be treated? Is it going to be treated medically or is it going to be treated surgically? And what kind of prognosis, what kind of outcome can be expected for patients who have suffered heart attacks? So the remaining questions which pertain to management, to outcome, to recovery, rehabilitation will be addressed in the second part. So thank you, viewers. Thank you, doctors. Stay informed and stay healthy.